Petrus will wait for 6 minutes.
Yeah, certainly. I think so.
Let people join.
Are your outpatients back to pre-COVID or not fully?
Not fully. तुम्हारा कैसा है?
No, not fully. I would say 70%. Maybe.
Exactly. मेरा भी वैसे ही है. 60-70
online. And there's still that online demand, which is still there.
Online has gone down, but patients are over 60-70. That's it.
No, so
another few months, maybe 3-4 months to really.
No, see, my online is running on a lot of outside Mumbai fellows who normally would have come and followed up.
Yes, yours must be out of the Mumbai. Yes.
But actually, it's got its own challenges. Follow up, it's okay, but when it comes to actually really taking decisions, it's got its lot of limitations, challenges.
So in the new patient which you see.
Right. So some new patients you can easily handle, but some news are you really can tell. I mean, you need to see the patient. I can't take a decision.
Yeah, I only see mainly the old patients. Those are old Parkinson's. कुछ करना ज़्यादा नहीं है, just some.
No. The old follow-ups. I mean, many times you wonder why the hell they were even coming from so far away to see you.
Yeah.
So those are fine, but I think it's the challenges are really when there are many decision points, lots of or a new patient which is very very odd. They're very difficult, and unfortunately we get a lot of the second opinion work, which is not so easy.
Yes. There you actually need to see them properly to really.
No, because I mean already they've been seen. There's some thought process that's gone, but they've not reached somewhere. That's where you're asking for another opinion.
True.
These are genuinely hard patients.
Yeah.
So we are live, we are audible and visible to the audience, and plus we are live on YouTube.
Oh, yes.
Okay. Then I'm actually glad that we didn't put a video into the case.
Name be avoid karna, Petrus.
Yeah, no name. So no, I don't think we ever use names in our presentations.
Sir has not yet joined, Mansi?
No, not yet. I'll call him up once. Just give me a
Rishika screen share and check the presentation. No?
Yeah.
Have you?
No, sir. Now.
No, he hasn't.
Okay, so just screen share only the first slide. Don't
Okay.
give the. So, but I think just to ensure that everything works smooth, because last minute you want any technical glitches.
Yes, sir. Is it visible?
Yes.
Okay.
You can stop sharing now.
Sir's number is busy.
Okay.
So, do you want to start or do you still want to wait?
No, Sarah just called me up. I just stopped.
All right.
Yes, sir. Sir has a meeting. So I think we can start in another 5 minutes. We'll wait and then start.
I, I don't know. I'm ready whenever you are. There are
Yeah.
33 participants apart from the panelists. So I have no idea what is the critical number you want to start at.
No, normally we start just few minutes. Let's touch. Normally, as we touch 50, we start. I think we can start, Patricia. So I'll just introduce you.
Done.
Yeah. So, good evening, all, and welcome to this fine evening session. Today we have a long discussion on extra pyramidal, and today our expert is Dr. Petrus Vadia. He is a well-known movement disorder expert, and he is a consultant neurologist at the Jaslok Hospital in Mumbai. So we look forward to your case, Petrus. So all yours now.
Thank you, Rakesh, and I think it's been a pleasure being back into Fine. So Dr. Rishik is going to be presenting the case. He is our second year neurology resident, and we have got the case. We are giving it to you as the patient came to us. The patient was first seen by me, I think somewhere in April 2019 or June 2019. So I think we're going to give you the history and examination findings then, and we are going to ask the experts to interpret that and give their own thought process. And then, of course, we'll even take thoughts from the audience, which you can type and send it to us on the chat box, and then we'll give you more details. So it's going to be a sort of step-by-step approach, but that's exactly how you see the patient when you see the patient. Okay, start the presentation, Rishik.
Yes, sir. Good evening, everyone. So, patient came to Jaslok Hospital in the month of April 2019, and it was his first visit. He's a
Rashid,
60.
your voice is little low.
Hello.
Yeah, now it is clear. Yeah. Okay, go ahead.
Yes, sir. So he is a 63-year-old right-handed gentleman. He used to go for a walk for half an hour daily. One day on the first week of October 2018, he noticed that he was having imbalance when walking. He started falling due to the loss of balance. He also started observing that he was walking slowly. In addition to this, he noticed that his other routine activities were also affected by slowness. After 1 week, he had a forward fall while he was walking. In November 2018, his son had noticed that his speed has reduced significantly and his imbalance when walking had worsened. He has had multiple falls. He had fallen on the face in a mall while walking, and also he had fallen backwards when he was unlocking the door. So, on negative history, he had no history of any motor weakness, no history of any sensory dysfunction, no history suggestive of cranial nerve abnormalities, No history suggestive of cognitive symptoms, hallucinations, sleep disturbances. No history of any dream and antic behavior to suggest REM sleep behavior disorder. No history of any involuntary movements. So starting with the discussion by interpreting the history, that
So
is,
Rishik, leave it at this. I think couple
yes,
of histories I think which we missed in the slide, and I had missed it even when I looked at it, is no family history of any similar problem, and I think there is no history of really any consumption of any drugs which probably could have caused any of these symptoms. We went to the drug history. So so now I think rather no history of any psychiatric treatment or anything like that. So now I think you can go and interpret the history one by one.
yes, sir. Firstly, what are the structures involved?
Yeah, so Rishik, let them interpret the history.
Yes, sir.
Uh, so sir, he's a 63-year male in his early 70s. He presented with imbalance while walking and walking difficulty with early falls within the first 6 months of onset. He had early falls, early and multiple falls, fewer forwards, fewer backwards. Imbalance in walking could be due to any site like cerebellar, sensory, extrapyramidal, pyramidal, etc. But because there is associated history of slowness of activities of daily living, slowness in other tasks, slowness in gait, along with that predominant early falls, I would like to consider the possibility of extrapyramidal syndrome first, with a possible localization related to basal ganglia and its connections. And because there is a history suggestive of early predominant falls, could be possibility of atypical extrapyramidal syndrome. But then I would like to examine the patient and as well as know the further progression to have any concrete idea regarding whether it's a typical or atypical extrapyramidal syndrome.
So here I'm going to ask you what do you think is against a cerebellar localization?
So cerebellar patient will typically give the history of broad-based gait with lurching, staggering type of gait. As like many of the times, patient's relative or patient himself describes more of a drunkard gait.
Sir, also
And
the falls are rare in cerebellar. When it is a very severe, then only they fall. Otherwise, they would manage to walk with lurching and swaying. So we could not hear you, sir.
Yeah, so I think one is you have to look at one is okay. So so one is cerebellum versus extrapyramidal is one thing. But many times the ataxia patients really don't give you that they're walking broad base, they're not walking like a drunkard. So you cannot completely rule out ataxia on history. And
yes.
just I mean, okay, the only thing that's favoring probably an extrapyramidal syndrome is the slowness, which I think you pointed out. Do you think there's anything with the time course duration of the symptoms that would raise a little bit of concerns? And Dr. Shirsar has already pointed that out in the question answers which he has put in.
Sir, is it acute onset or is it insidious onset? That is not clear from the history.
The history is as it is. Go back to the previous slide, Rishik.
Yes, sir.
The first slide, maybe. Yeah, so one more. So it started one day when he was walking in October, and then the next slide in November. Go ahead. So this is obviously okay. It's not absolutely acute like a stroke in minutes and hours, but definitely, I mean, when you're talking about a Parkinsonian syndrome, I mean, this is not a slow onset.
Yes, sir.
Yes.
Tempo of illness is bit rapid for the neurodegenerative process.
Correct. So this is something that should raise an alarm and should ask you to think a little bit more. And I think that's very well pointed out by Dr. Ashok Shirsat. I mean, years of experience tells him that you have to smell a rat here. Something is wrong. Something is not right. And so I think this is something that I wanted to raise also. That it's very rapid. Agreeably, the number of falls that has happened in a very short span do make you worry that this is obviously not typical Parkinson's, and that is very obvious, I think, to anybody who's reading the history that this doesn't look typical Parkinson's. So apart from the falls, any other red flag? So when you're looking at Parkinson's versus atypical Parkinson's, you're looking for the red flags, the pointers to tell you that this is not Parkinson's. So one red flag is the falls. Any other red flag?
Sir, rapidly progressive, then absence of tremors is not.
Tremor can very well be seen in on many of the PSPs. So PSP-P can have tremor, MSA can have a jerky tremor. So I would say absence of tremors means nothing. But yes, the rapidity of onset very much raises the point. Very much so. So rapid onset and multiple falls make you feel that probably we should keep the possibility of an extrapyramidal syndrome, probably atypical, and I think then assess more. There is some more things in the chat. Yeah, so I think somebody's raised the possibility of normal pressure hydrocephalus. Point taken. So you will definitely do an MRI. So my question to you, to the audience is, while we're at it, so you sort of said extrapyramidal syndrome, you said atypical Parkinsonism. So what are the secondary syndromes which can mimic an extrapyramidal syndrome like PSP? So what are the secondary causes of Parkinsonism that you will think of? Which
Vascular
can
causes.
So how common is vascular Parkinsonism, may I ask?
Not so common, very uncommon.
Correct. So common things common first.
NPH,
And
first NPH.
so let's put hydrocephalus rather than NPH.
Yes.
It could be obstructive or normal pressure hydrocephalus. Okay. So,
Yes, sir.
so and on the history, it's hard to tell for NPH because I mean you cannot assess. You've not got all the other features. So yes, any hydrocephalus, obstructive or normal pressure. Then.
Sir, repeated trauma to the head.
Yes, but there's no history of that here, right? So
Then
that would not come up.
Yes, drug induced.
Drug induced very common. Many a times goes unrecognized.
So drug induced trauma.
Toxins.
Which toxins?
For MPTP.
Manganese. MPTP.
Lead, manganese.
Okay, so any examples of manganese toxicity which you'd like to tell us about? So where can you get manganese?
Miners.
Correct.
Coal miners, dry mining of manganese.
Okay, so manganese in miners. Any other situation you can get manganese? Anybody in the audience of any other instance which can cause manganese toxicity? Non-occupational. Let me put it this way. So there was a huge incidence in Eastern Europe of manganese toxicity where they were making some locally made. There was a Google recipe of making ephedrone, which was one of these drugs. So in fact, there was a whole lot of people, mainly of Eastern European origin, who got manganese toxicity by creating a homemade recipe. It was literally like creating your own concoction, and they actually lost speech completely, and they couldn't get their speech back. There's a lot of publications in the early 2000s on manganese toxicity because of trying to make your own drug, as you call it, to get a high. So that's one instance which manganese poisoning has occurred. Liver is another instance. If you have severe liver involvement, you can get manganese toxicity. And that's the reason why you get T1 hyperintensities in bilateral basal ganglia in patients with liver disease. So that's another situation you'll get it, but typically not very clinically significant necessarily so. But liver, minors, and then this rare situation where people have done it for recreational purposes. So you've talked about hydrocephalus. You've talked about. So I'm coming to vascular. So there's a paper I think a year or two ago on whether vascular Parkinsonism as an entity truly exists. So there's a paper with Tony Lang as one of the authors where they've talked about pseudovascular Parkinsonism. I'd urge you to read that paper. I think that the argument is that vascular Parkinsonism is overdiagnosed. Vascular Parkinsonism, true vascular Parkinsonism only occurs if there's an infarct in the substantia nigra, which has affected the dopaminergic pathways. Everything else, which has been termed vascular Parkinsonism, is not true vascular Parkinsonism. It's an interesting paper, worth a read, definitely worth a journal club. So it's definitely something that you can read. I'll try and share the link later on for this paper. So that is definitely one of them. Tumors occasionally can also present as PSP mimics. Then there are certain genetic syndromes which also need to be considered. Any idea of them?
So Niemann-Pick's type C, then also Whipple's.
Niemann-Pick types. One minute. What's the age of this gentleman?
Sorry, old 63.
Yeah. So you're not looking at Niemann-Pick type T, nor you're looking at Whipple's. So you're looking at a group of entities called as what Kailash has in his papers termed as atypical Parkinsonism. So these are people who have genetic abnormalities like dynactin mutations causing Perry's syndrome. So these are a few rare syndromes which can look like PSP. So that's another paper that you should look at, atypical Parkinsonism. Kailash Bhatia is the main author. Basically, they've talked about odd genetic syndromes that can mimic PSP, MSA, CBS. So definitely worth a look.
Yes, sir.
So there's somebody talking about IG-LON5, autoimmune. They've talked about it, alcoholism. Alcoholism alone will not cause extrapyramidal unless there's Wernicke's. So IG-LON5 has a very different phenotype. It causes excessive sleepiness. You'll get myoclonus. So IG-LON5 is, I think, is a slightly different phenotype to this. But yes, we did consider autoimmune, which we will talk about later. So I think now go ahead with the examination, Rishi.
Yes, sir. So on examination, his vitals showed pulse was 80 per minute. Blood pressure on supine was 124 by 80 mmHg, and on standing it was 120 by 80 mmHg. On central nervous examination, his higher functions were normal. Speech was hypophonic. He had masked facial expression. On cranial nerve examination, he had restricted eye movements, vertically more than horizontally. And on optokinetic nystagmus, he had mild impairment of corrective fast saccades. On motor examination, the nutrition was normal. Tone had rigidity more in the upper extremity than the lower extremity, and in the upper extremity, right upper limb more than the left upper limb. Power was 5 by 5 in all the four limbs. On bradykinesia assessment, finger tap test had significant bradykinesia, right more than left, and on alternating movements, he had significant bradykinesia of the right more than left, and on foot tap test, there was bradykinesia again on the right side more than the left side. Coordination, he had mild finger, nose finger ataxia in both the upper limbs. No involuntary movements were noted. Reflexes were normal in all the four limbs. Sensory examinations showed all sensory modalities were normal. And on posture and gait assessment, he took 3 attempts to get up from chair and kept falling backwards. His posture was erect. Stride length were decreased. Base was normal. Reduced arm swing bilaterally. He had freezing of gait, and also full test was positive. He was also unable to do the tandem walk.
Stop at this point. Now I think you all need to now come to decide whether you're going to change your impression which you had at history after the examination. or whether your examination confirms what you were thinking at the end of history. So
Yes.
maybe we can go with Abhay first.
Yes, sir. Again, it is suggestive of a more likely extrapyramidal system because hypomimia, also rigidity is there. But although some asymmetry is there, that is right is more affected than the left, and less likely to be cerebral because there are no clear-cut cerebral signs are there on examination. Also, sensory system is normal.
Right, but cerebellar is involved. There is finger nose finger ataxia. There is tandem gait. He was not able to do tandem gait.
Sir, but
So
actually, if there is a postural instability and rigidity, then how we can interpret it to say that?
so let me ask you a question. Can patients with Parkinson's do tandem gait or they can't?
Yes, sir, they are able to do tandem gait, but he is not able to. Postural instability in this patient is very severe. That's
No, so people who have a positive pull test can very much do tandem gait. There is no question about that. So just having postural instability does not mean the tandem gait should be abnormal. In fact, if you have an abnormal tandem gait in a patient with Parkinson's disease, it is 100% atypical Parkinsonism. It's not Parkinson's disease. Parkinson's disease, even 20 years down the line, should have normal tandem gait. And if there is a tandem gait abnormality, in fact, it is considered one of those typical signs of MSAP. So if you have an abnormal tandem gait abnormality, think MSAP. Don't think Parkinson's. So clearly tandem gait abnormality cannot be ignored and it cannot be attributed to postural instability. I disagree completely on that. And there are lots of papers on tandem gait abnormalities as a pointer to the patient having MSA. So no, I would be completely not in agreement on this point.
yes.
So you cannot a finger nose ataxia is something that you cannot gloss over either. So these 2 points, okay, you can say that the flavor is extrapyramidal. I would not argue with that, but you're going to have to explain the cerebellar involvement.
Yes, so then with extrapyramidal with cerebellar involvement is there, and some asymmetry is there. So right is more affected than the left.
So does the asymmetry bother you?
Sir, then again we should think of a CBS or PSP CBS.
Yeah, so a lot of PSPs have asymmetry. It's only when there's huge asymmetry that it really bothers you.
Yes.
So minor asymmetry is there in almost all the Parkinsonian syndromes. The massive asymmetry that you will get in a CBS, that's different. But then there's nothing else that suggests of CBS, at least in this examination finding that is told. There's no posturing, there's no apraxia, no cortical sensory impairments. None of that has been told to you.
Yes.
Yes. So plus brainstem involvement is there with extraocular movement abnormalities.
Correct. So now what do you think at the end of history, at the end of examination? Where would you?
Sir, phenotype suggests is more of a PSP variant, but there are some red flags against PSP, and there are some features suggestive of MSA type phenotype as well, but there are again few red flags against which as well. So onset at the age of 63 years with rapidly progressive Parkinsonism, mild asymmetry, early frequent falls with vertical supranuclear gaze involvement suggests is more of a PSP, but then against involvement of cerebellum would point against PSP. While in case of MSAP, usually the onset is little earlier, around early 60s. Plus, extrapyramidal means Parkinsonian signs in MSAP tends to be more of a symmetrical, and there are early REM sleep as well as sleep abnormalities in the form of parasomnias and striders, breathing problems, etc. in the MSAP.
So do you get stridor so early in the case in MSA?
No, sir, no.
No. So you're not expecting stridor so early in the game, right?
Yes, sir. But sir, REM sleep abnormalities could be early.
True. That I agree. So there's no REM sleep behavior disorder. There's no dysautonomia.
Yes, sir.
That we are aware of. Now my question is, how problematic would cerebellar signs be for your diagnosis of PSP?
So PSP cerebellar variant is also now described.
Correct. So that's a good point, Abhay. You can get a PSPC, So you can, so there's clearly a PSP cerebellar, so you can get cerebellar involvement in PSP. So just the presence of cerebellar involvement when everything else has a flavor of PSP should not alarm you.
Yes, sir.
But there's definite rapidity in onset, which definitely should make you think of the secondary causes as we discuss. So I think the rapidity of the situation cannot be ruled out. I mean, cannot be just glossed over here.
Yes.
Any other thoughts in the chat? Let's just quickly go through. Yeah, so somebody thinks, so the question is, would you still keep hydrocephalus or NPH as your differential after you got all these examination findings?
No, sir.
Lots of, it doesn't give you a
Any,
flavor of NPH.
no. It's not a question of flavor. Look, we can't run on flavors here.
Yes, sir.
We have to run on hard evidence. So what is the things that are against NPH in your examination?
Sir, urinary incontinence is not there.
Positive things in the examination first.
Sir, gait instability is there, but does not look like frontal gait. Looks more of an extra pyramidal gait.
Can you go back to the examination pages, Rishi?
Yes, sir.
So, what is NPH typically? Which area of the body does NPH catch?
So subcortical area is involved.
Frontal subcortical circuits.
Do you get upper limb involvement in NPH?
No, sir.
No,
It's a
sir.
lower limb
So,
Parkinson.
if you get upper limb involvement, firstly, that's not like NPH, right?
Yes, sir.
Second, do you get extraocular movement involvement in NPH?
Which one? Extra?
Extraocular movement.
No, sir.
No, sir. No extraocular.
So, and do you get speech involvement in NPH?
Can be there.
Go back one more slide back, please. So speech involvement, extraocular movement involvement, upper limb involvement are things that are not seen in NPH, at least in pure NPH. Okay, let's put it this way. Okay.
Yes, sir.
So I hope you all understand that NPH itself is a whole rag bag which we don't know. So in pure NPH, you should not get eye movement abnormality, you shouldn't get upper limb involvement, and you shouldn't have much of speech impairment. All your gait abnormalities can be accepted. You cannot tandem gait in NPH, which is very common. You'll have freezing in NPH, which can be seen. And you can have a short-stepped gait. You can have postural instability. All that can be seen in NPH. But you will not get upper limb involvement typically in NPH. And you will not get eye movements. You will not get speech. Now, to add to your misery and complications, there are a lot of papers that actually have followed up patients with NPH. There's one by Alberto Espe, which I think you all should read, which is an interesting one, which has actually followed up patients with NPH over a period of 3 years. And a lot of the people who actually were diagnosed NPH, shunted, etc., had worsening over a period of time, and a lot of them evolved into PSP. So there's a lot of thought process that actually NPH could be an early manifestation of PSP, because all that you're seeing is dilatation of ventricles. And it's always been a debate whether dilatation of ventricles is proportionate or disproportionate to atrophy. Many of them even respond to the lumbar tap test, they even respond to shunt. But that response is short-lived. It's not long-lived. So a lot of people who had so-called NPH, in inverted commas, when you follow them up for a period of few years, will actually evolve into another neurodegenerative disorder. It may be PSP, it may be Alzheimer's, it may be something else. So in fact, when you have an NPH, now I counsel all my patients that we don't know whether the NPH is pure or is part of a neurodegenerative disorder, but we can attempt to give you symptomatic improvement for a couple of years. So it's still worth doing a programmable shunt. But you have to understand that it may not be long-lived and you may be evolving into a neurodegenerative disorder, which we don't understand today. So even the NPH is a mixed group, but pure NPH should not have all the characteristics we discussed.
Yes.
So that was, I think, one of the attendees very rightly pointed out that the NPH is probably not a thing that you look at now. Okay, Rishi, can you go ahead with the investigations?
Yes, sir.
Before I go ahead, and Rakesh, any points? Go back one slide. Rakesh, you want to add any points?
Peter, it's going very nicely. I think we continue.
Okay, perfect. Thank you. So, Rishi, go ahead with investigations.
Yes, sir. So we did investigations which were done prior to his visit, and his CBC and ESR were normal. Thyroid function test, LF liver function test, and renal function test were normal. Vitamin levels were checked, that is vitamin A, vitamin E, vitamin D, and vitamin B groups were also normal. His sugars were normal, and testing for spinocerebellar ataxia 1, 2, 3, 6, and 12 were also negative. His EEG was also normal, and heavy metal screening was also done, which was negative. His MRI brain was done, which showed subtle features of midbrain atrophy, and other than that, everything was normal. And MRI cervical spine showed no cord compression. This is the MRI brain of this sagittal view.
Stop at this point. Let's ask the panelists what do they think of this.
Yes, sir. So MRI brain is almost normal, other than the subtle midbrain atrophy. So acquired causes have ruled out, sir. Like,
No. I want you all to interpret the image, not about anything else. So interpretation of image is what I'm asking you.
So there is a cerebellar atrophy is there, that clear folia with sulci is seen. Then midbrain tegmentum looks okay because the upper border is not concave.
Right. No. So my question to you is there a hummingbird sign or not? Simple.
No, sir.
No.
Okay, fine. That's what we wanted. But I would say that there is no hummingbird sign on this image either.
Yes, sir.
This is an SWI image sequence of the same patient, axial view.
Go on.
So now the patient came to Jaslow Hospital in the month of June 2019, and this was his second visit to Jaslow Hospital. So this time he felt that the imbalance had worsened to such an extent that he had difficulty standing. He also required one person to support him while walking. Also, he had subsequently noticed stiffness on the right side of the body. He had 2 falls after the April 2019 visit, and also he had developed constipation. And on central nervous examination, he had eye movement abnormalities, which impaired corrective cycles on Ocane. The rigidity increased significantly in the right upper and lower limb, predominantly in the right lower limb. Pull test was positive, and the postural imbalance worsened. He fell back to chair when tried getting up from sitting position when his hands were folded. And on gait examination, he needed support of one person to walk.
So I think we stop here. I think I want you all to get an idea of what has happened. It's really, I think that the difference between these two is about a period of 2 months. But do you would like to change any differential diagnosis, any different thought process?
Sir, there is again, sir, there is rapid progression of symptoms, relatively very rapid, with marked means apparently more asymmetry apparent on the examination. Plus, there is a right upper limb stiffness, which could be either spasticity, rigidity, or could be either spasticity or rigidity. So this is something I would like to see on examination in detail, what kind of rigidity has significantly increased. And sir,
Mhm.
there is
This is examination. This is
yes
not
sir.
history. So you've
And sir,
got your examination. This is what it is.
and sir, there is a history suggestive of positive rocket sign when he's trying to get up from the sitting position, which could suggest PSP, point towards PSP more.
Right. But does the rapidity bother you?
Yes, sir, it's very fast.
So would you like to think of something else as possibilities?
Sir, more
In
than neuro.
in 2 months, this person is now requiring support to walk. Doesn't that concern you?
Yes, sir. Yes, sir. Neurodegenerative process wouldn't be progressing this rapidly usually.
Right. So I mean, now the family is holding your neck, and they're going to tell me, Doc, what's going on? What
So
are you going
as
to do?
sir, as the patient has been screened for few genetic conditions like scars and all, heavy metal has been screened as well. So I would like to
Yeah, but I
consider
mean,
possible.
honestly, you don't think heavy metal really was a cause. It was done by
Mm,
somebody. I mean, I probably wouldn't have sent it myself. It was
yes, sir.
done because I think one of the labs has heavy metal as part of their panel. That's all. And
Yes,
and even scars. I mean, there was a question from the audience why it was sent. I probably wouldn't have sent it. Not at least at the initial visit, but yes, if I was absolutely pulled against the wall and had to produce differential diagnosis and you came up with scar 2, 3, then you would have sent it. But well, it was sent, but I mean, that would have not been my first investigation. Let's put it this way.
yes, sir. So I like to consider for any autoimmune or paraneoplastic means autoimmune possible causes because of
Okay,
the rapid progression of symptoms and one of the treatable causes. I would like to keep it higher on the cards.
point taken. Autoimmune, yes. Paraneoplastic, yes. Any other?
So CGD also can be out because it is very rapid.
Prion, very good. Yes. All
Other
of our, all.
atypical infections, CSF should be considered at this point.
Is there any evidence for an infective cause? Okay.
No.
Yeah, we have occasionally seen neurosyphilis that sometimes can mimic a Parkinsonian phenotype, but eye movement abnormalities of this nature, no. Okay. All right. Rishi, give us the investigations at this point.
Yes, sir. So in June 2019, he underwent a Trodat scan which showed reduced dopaminergic activity in the left putamen.
So I think this was required because now the questions, as rightly a lot of y'all have pointed out, was it a Parkinsonian or dopamine deficiency syndrome? So at least the idea of doing a DAT scan was that at least you confirm that you're actually dealing with a dopamine deficiency syndrome. So all the other thoughts, whether it's an infective process or whether it's drug induced or toxin induced, if you have dopamine deficiency, you virtually at least that abnormal product would be against a drug induced or would be against an infective cause. Okay. Yeah. Anything else, Rishik? Next slide.
Yes, sir. So, sir, in the next visit, that is the third visit, was in the month of January 2020, where over the last 2-3 months, patient required more support while walking. He needed two of his relatives to support him. He is
Yeah.
hardly
Just I'll
walking.
just stop at this point. 1 second, Rishik. Sorry. I just like to say you only put representative visits. We've been seeing this gentleman rather too often, more than my regular follow up, because the family is panicking because he's had such a rapid tumultuous course. So I mean, we've only put representative visits because otherwise this would have never ended. But just to tell you that we've only put certain representative visits, and they've been met much more in between. Go ahead, Rishi.
Yes, sir. So he is hardly walking since 1 week. His speech had worsened. The relatives had to help him feed food, and he continues to have constipation. Also, he had difficulty to use his right hand for combing and brushing. So this time, the examination findings were marked dysarthria he had severely restricted vertical gaze, wasting of right upper limb, predominantly the forearm, the thenar and the hypothenar muscles. Axial rigidity increased, and it was markedly increased compared to the appendicular rigidity. Apraxia of right hand was also seen, used right hand as a tool, and cortical sensations were normal. His gait worsened. There was significant freezing when walking with support, and on pull test, he was falling backwards on examiner's hand.
I'll just like to point that the walking with support, what Dr. Rishik is mentioning, is walking with a hell of a lot of support. Okay. Go on, Rishik.
Yes, sir. So the clinical assessment till Jan 2020, that is the course of the disease progressed over 1 year and 3 months, and the predominant important features which we saw
Yeah, so
here.
I think stop at this point. Everyone can read it. Let Abhay and Mehul come up with what they think.
Yes, sir. So there are new findings we get. That is apraxia is there, and also we got the right upper limb wasting, that is lower motor neuron involvement there. That can be seen again in PSP because it is a tauopathy. So CBS and also sometimes MND like ALS like features can be seen.
Good point. So you can think of FTD with motor neuron features.
Yes, sir. With
Yes,
So
sir.
FTDP, yes.
Yes. Sir, again, dysarthria would favor PSP type phenotype, early dysarthria.
Okay. So you've got a new finding of apraxia and you've got a new finding of upper limb wasting, and there's been further worsening.
yes.
Yes.
So what would you like to do at this point? Any investigations you'd like to do?
Sir, autoimmune panel and PET-CT should be considered before, just
Okay,
to rule out
I
treatable.
think Rishik will be showing you the results, I think, in the next slide.
Yes, sir.
For
Yes,
both.
sir.
Anything else you want? Before Rishik showing the final investigation. Yes, somebody's hit the nail on the head in the audience. Yes, EMG is something I was looking for from you all. If you're thinking of ALS, you're definitely going to look for
Yes.
anterior horn cell involvement. So I think before you do a PET-CT, you'll at least put it in a needle and at least find out whether you're actually dealing with anterior horn cell or not. Okay.
Yes, sir.
Okay, Rishik, go ahead.
Sir. So investigations. So we did a whole body PET-CT in October 2019, which showed moderate hypometabolism in cerebellar, bilateral medial frontal and anterior cingulated areas, bilateral lateral frontal, parietotemporal, brainstem, right putamen and left putamen, and global cerebral. This is the PET image where we can see there are bilateral cerebellar hypometabolism and also in the frontal lobe.
Okay.
Now, the other investigations in November 2019, the patient had two opinions in US, Dr. Adam Boxer and Dr. Aaron Litwin. And based on their opinion, the investigation net cast wider, which involved paraneoplastic panel, which was negative. Autoimmune profile and neuronal antibodies were also done, which was negative. Anti-gliadin antibodies was sent, which was negative. EMG NCS was done, which was normal. And for prion disease, 1433 was suggested, but it wasn't possible. We couldn't do the test.
So we had even discussed the possibility of doing a CSF. Somehow the family was not very keen of something invasive if there was nothing going to come out of it. And he's saying, if you find prion 1433, if they're going to give me no treatment, then what's the point of doing it? So which is a valid point. And they actually met both Dr. Adam Boxer and Dr. Irene Dittman with the patient in November, I think 19, well before COVID, luckily. and both of them felt that we had literally done everything we had, and they had few suggestions, and this is where we are. Go to the next slide, Rishi.
In December 2020 was the last visit where patient came to Jaslok Hospital, and patient needed full assistance to make his stand from sitting position. He was unable to get up from lying position on his own. He started having urinary incontinence along with constipation. Also, relatives needed to be around him all the time as he had high tendency of falling. On examination, his speech worsened. He had dysphagia, rigidity increased in all the four limbs, and on gait assessment, patient was hardly able to walk. On trying to walk with support, he had significant freezing, and also his steps were very short.
I mean, here actually, I think the walking was only for the relative satisfaction. For all practical purposes, he's wheelchair bound. It's just so that the relatives felt that haan chal raha hai, so that they were trying to make him walk and do physiotherapy, which often happens in a very severely neurodegenerative patients, where the relatives feel that the wheelchair should be avoided as far as possible. But practically speaking, he was wheelchair bound. Okay, Rishik, next slide.
Yes, sir. Then the most recent investigation we did is genetic testing, where we found that HTRA2 gene phenotype came out to be positive, which was a heterozygous and it had an autosomal dominant inheritance, but had uncertain significance. And CNORF72 test was not tested.
So we'll stop with this one. The reason we asked for genetic testing was when the ALS kind of phenotype came up. So we were wondering whether we are dealing with FTDP gene. So that's when we thought we can do a genetic testing looking specifically for the MAP gene and for C9orf72. Unfortunately, C9orf72 is a triplet disorder, so it cannot be tested on a standard exome sequencing. What we've seen here is probably, we don't know whether there has any significance at all. So HRA2 mutations not been described with PSP at all. And there are a couple of people where they've said that it could be PARC13, but it's really a susceptibility gene, and really the significance of this HTRA2 is not known at all. So really, I think for all practical purposes, the genetic testing has raised more questions than answers. Can you give us some more slides on this, Rishi?
Yes, sir. So next slide is based on this STRA2 gene mutation only. So this STRA2 protein is a serine protease which is targeted to the mitochondria and plays a role in apoptosis. There is evidence is also reported that STRA protein is found in Lewy bodies. A mutation in the STRA2 gene were recently designated a novel autosomal dominant Parkinson's disease, that is PARC13. And mutation of STRA2 was nominated as a novel cause of sporadic Parkinson's disease and was associated with increased risk of disease. And this has been mentioned in an article where the study was based on genetic variation of OMI, STRA2, and Parkinson's disease by Dr. Owen A. Ross, Dr. Alexander Soto, and Dr. Matthew J. Farrer.
Next slide, Rishi.
Yes, sir. So now the next slide is based on final discussion points.
Right, before we close. So I think don't show the next slide, just stop this.
Yes, sir.
Yeah, so would you like to have anything else to say after all that we've done?
Sir, more like
any other interesting?
No, sir, more likely a
No, sir.
Yeah, Abhay, go ahead.
Sir, mostly we have ruled out all possible acquired causes, sir. So more likely it is a neurodegenerative process, but still odd that it is very rapidly progressing because most of the PSPs they progress in around 3 to 5 years. So he progressed in almost 1.5 years to the wheelchair bound.
Correct. So if you have to put a subtype to PSP, which subtype would you put this?
So more like a PSP CBS FTD. because they are tauopathy. So all this, sorry, not FTD, sir. It is a
PSP series.
ALS.
So of the PSP subtypes, which is the most rapid progressive?
Classic variant is most rapid.
So what is that called?
Richardson variant.
Richardson syndrome. So this is PSP, if at all it is PSP. And the wasting is something that even we are not able to explain, but the EMG was plumb normal. So
yes, it can be because of disuse.
Maybe disuse, but a little alarming.
The apraxia can be explained by PSP Richardson variant.
So there's often a lot of overlap in the tauopathy. So a little bit of apraxia can be seen in PSP also. None of these diseases are pure anyway.
Yes, sir.
But he's not a standard phenotype to begin with. And the only thing we haven't done is a prion test. And frankly,
Yes.
I mean, at the end of 2 years, the possibility of prion anyway, I think, drops.
Yes, sir.
I mean, it's very unlikely that you're going to get prion at 2 years from the onset, which is now the case. So really, I mean, the lack of a 14-3-3 protein, I don't think should change anything in my view at this point.
But his cognition has remained normal over the year.
Well, he can hardly speak now. So really, I mean, to say that it's very, very hardly, I mean, difficult for them to really say, but they keep saying his cognition is sharp as ever. And he's very depressed now because he's seeing himself in the state. And we've been battling with depression and the children. So you can realize, and the fact that you can go to see Adam Boxer and Irene Litman means you obviously come from very good backgrounds.
Yeah.
Where you can afford the best for your parent. And they are like continuously coming up with different articles but yeah, I mean, obviously everyone's very anxious and very upset about the whole situation, but I can't see anything I can offer him. And he didn't respond to any amount of levodopa. We've tried the works. We've gone up to 16 tablets a day. Not even an inch of response. But that is typical of PSPRS. They just don't respond. And it's heart-wrenching to see them go down. And I can anticipate that within a few months we'll be at the stage of a peg tube. We've already talked about it because the swallowing getting worse. That's going to be another whole lot of convincing to done. But I mean, you can see that a peg tube is coming.
Any thought about using immunotherapy, or was the immunoglobulins, because the way he's rapidly gone down, it seems like paraneoplastic cerebellar.
We look for So we did look for it. We did the whole paraneoplastic panel. We did the whole CT. We did whatever the autoimmune panel that is available today. Obviously, we can't test for the things that we don't know. But there is evidence to say that this is an autoimmune process. And we did take our opinion from both Irene Ditwin, who is at the top of the helm of PS, probably know. Even really into cognitive neurology. He did a detailed neuropsych assessment also. There, nothing really on the neuropsych also, which was found. Both of them have thought that this was a very rapidly progressive PSP phenotype, but yeah, we do. None of them thought that we should empirically treat it with immunotherapy. Okay, we'll go to the last slide.
Yeah.
Yes, sir.
Yeah, go ahead, Rakesh.
I was just saying it's a very difficult and difficult situation.
No, difficult. And that's what I told you when you discuss it, is that we'll discuss it, but I don't have all the final answers. So go to the last slide. This is just what I put my thoughts on the paper in the last slide, literally.
Yes, sir. So at the end, this was our view. The phenotype is that of a rapidly progressive supranuclear palsy of RS type. Secondary causes, we check for secondary causes, that is autoimmune paraneoplastic with no evidence so far. Prion pathology, already 2 years since onset, no MRI evidence so far. And on genetic causes,
and we've had multiple MRIs in between, and so no diffusion restriction, no cortical ribboning, nothing else. That the typical features. Prion features. Go on, Rishik.
On genetic causes, there was no conclusion, and we could not test C9 or F72. We looked for PSP MND phenotype, but EMG showed no evidence of any anterior horn cell pathology, and there was no mutations in MAP gene either.
Yeah, Petra, there is a interesting question by Dr. Sirsat.
Yeah,
Do we?
I just saw that.
Absolutely correct.
Yeah, so I mean, I mean, you can theoretically give a trial of steroids, etc. But I mean, the point is that such eye movement abnormalities in autoimmune pathology, I have not come across. But I mean, you can also give an empirical steroid immunotherapy trial, and I don't think anybody will be wrong in their thought process. We've not done one, but
Some of the questions are there, Petra's. Yeah.
yeah. So I think about how to treat such patients. I mean, thankfully these are rare. So I mean, even we struggle, and we've also not just left it like that. And
Yes.
yeah, I think the rest of the question, I think we've dealt with. So I think the reason for showing this case was one, an approach, and to start your thinking beyond just the basic phenotype of just looking at PSP and ending it at that. Thinking beyond, thinking of secondary causes. And obviously, I mean, even the first thought, I realized that at the end of history, people think PSP. But the idea was to sensitize you that there's lots more to the whole thing than just PSP. And also to realize that you have to face these people recurrently. So you have to really look into all answers, all possibilities. And there's a lot of talking that has to go on, backed by evidence.
Yeah. Very difficult to face the relatives, with the things going down so quickly.
No, agreed. So you have to continuously be there to provide support, to provide help. But I think where the education of they're so educated, they've done their Google research.
Yeah.
But it's heart wrenching. I mean,
I was just thinking of worth giving a try of immunoglobulin. As Dr. Sirsad also felt, we don't know all the autoimmune ailments or the way he has gone down.
probably I'll put it to them. No harm done.
But excellent case. It was fantastic case, thought-provoking case, rapidly progressive PSPs.
No, but that is the reason I wanted to show it, because
Yeah.
it's one of these cases that's given me a lot of thought, and we've put in a lot of efforts.
Yeah. Excellent. Fantastic. I just wanted to ask Petrus, this rapid onset Parkinsonism. I don't know how. I've never seen a case of that. That is DYT 17.
So no. So there's rapid onset dystonia Parkinsonism.
Yeah.
So that's DYT 17, but there it's an acute onset.
Acute onset.
It's it comes as an acute onset, and then it can come stop start, and you can be left with severe dysarthria. It comes and it's dysarthria is the very dominant feature there. So dysarthria and hemi-Parkinsonism or dystonia. So, and the mutation is 8013.
Age is younger, or it can be seen in adult also.
No, so wraparound dystonia Parkinsonism is usually younger, but it's the same gene as that causes the hemiplegia of childhood. Trying to remember that. ATP13 is the gene. Alternating hemiplegia of
Excellent, I think. Fantastic case.
okay, but I think the argument that the residents have had, I think, has been pretty good. I mean, they've discussed it very well. So I think the idea was to give you all some insights into Parkinsonism, their approach, secondary causes, also the red flags. So I hope points out in the discussion.
Fantastic case, Petrus. It was really good. You showed a very nice approach of little oddish case, how to approach and all the findings and excellent. I agree. It must be really very good for all the DM students.
Okay. Thank you very much, everybody, and thank you for the opportunity of showing this case.
Thank you, Petrus.
Thank you, sir.
Thank you, and thank you
Abhay Mehul,
to
fantastic.
Shirsak for your free.
Thank you.
Fantastic.
And I think we need to thank Dr. Shirsak for his participation and eager participation in the discussion.
And raising very minute and very sharp points. On first slide he picked up.
Absolutely.
It's something else is happening here. Fantastic.
Absolutely. And I think for all the audience, for being a good audience and participating and keeping the discussion live.
Okay, Petrus. Chalo, good night.
Okay. Bye-bye. Thank you.